So today I'm really just going to do the introduction because the main event really is to talk us through and hear more about the tests of change and the sites promoting physical health outcomes for mental health sites. In terms of the background for Health Promoting Health Service, I'll talk a little bit about that and its delivery, and really about how the agenda and the Chief Exec letters that we've got for Health Promoting Health Service help support this agenda for improving health outcomes and physical health outcomes for mental health, and some of the key drivers. So, and as well as that, just to talk a wee bit about how it's aligned to the quality strategy, because that again is one of our key drivers. So this actually goes back to the mists of time, and Health Scotland and its predecessors have been involved in supporting local boards and practice in delivering health improvement and health promotion in primary care and secondary care for many years now. One of a key driver really and a turning point was the development and dissemination of a Chief Exec letter in 2008, and that really was a cluster of evidence-based interventions that are focused on secondary care, and the scope of that includes mental health hospitals, units, settings. We're now in year 3 of the Chief Exec letter for 2012, and physical activity has been added to that range of options. We have to really accelerate the delivery, because we have had reports, and we've done monitoring reports over the last couple of years. Really to accelerate delivery on that, we now have a ministerial working group and non-executive champions from each of the health boards to support this work. And because we're in the last year, so the final reports will be coming in April, we're looking towards a further inequalities focused, which really does scope in mental health, because we've heard about that earlier from earlier speakers, for next annual reporting year, and then looking forward really about looking at the greater contribution to inequalities that this agenda makes. So really this is just part of the puzzle for Health Promoting Health Service. Contributes part of the puzzle. It's not the whole picture, but the focus is secondary care at the moment. And really the strapline we have is every healthcare contact is a healthcare opportunity, and it really does chime home when you hear things like don't just screen, intervene. You know, that really, we should have that alongside, because in secondary care there's a lot of data collection at first booking. People are booked in, we know their smoking status, we know various other things about them. In mental health it's not done as routinely, but we'll hear about from the test sites how that's changing. But we don't necessarily always intervene for lots of different reasons. So part of this programme is about trying to change that culture of practice. And the underlying principles for Health Promoting Health Service, these are old WHO, World Health Organization principles around equity, participation, empowerment and sustainability, and they chime exactly in line with what we have in the healthcare quality strategy, and really align well, and the cell interventions themselves support the 2020 vision. We heard earlier about that, about being enabling everyone, but actually as well it's about that integrated health and social care system having a focus on prevention and also self-management. So the empowerment bit here is really key, I think, in mental health settings, and I think that's also been talked about earlier. That's the core actions and the interventions within the Chief Exec letters at the moment. And I guess just to pick out a few of those, so again, just to reiterate, mental health settings are within the scope of this. All health boards are required to deliver and report on these annually. Each health board has a governance structure that they have to report to their board, and they have a strategic group that supports the delivery of this work, as well as now their champions, and we have a ministerial group. So we have ahead a body of steam around this, and national scrutiny around it, as well as local governance. There's a couple things on the year 2 reports and year 1 reports. We definitely saw that mental health delivery was not working as well, and we didn't have either as good reporting, or actually just delivery wasn't up to the same level in terms of delivery for other secondary care settings. I have to add that secondary care settings do also have a way to go, but there were some key areas of improvement around, and we've heard about that, someone's mentioned it already, around training, mental health literacy of staff in general settings, and also medical leadership, and I'll come to that later. But in terms of some of these topics, smoking is a key one. We've heard about that already. So at the time of reporting for year 2, so last April, only 2 boards have dedicated or reported having dedicated specialist smoking cessation services for their mental health services. So now that's not necessarily a bad thing. It may well be that there's good pathways from mental health settings to community services, but it does indicate that we do have a bit of work to do around pathways and being really clear about that. And for smoke-free status, now there are, obviously you'll know there's exemptions for smoke-free, and we've just actually been involved, and I've been coordinating a campaign. You might see it on the telly. It's about smoke-free NHS grounds. Now, at the moment, we have exemptions for mental health, but that, in a sense, the National Working Group for that, for smoke-free grounds, really the view is that as an aspiration, really, and for equity of outcomes, and if we're to protect physical health and support the prevention of ill health, future ill health, really we need to be moving towards smoke-free grounds for mental health settings as well. Why wouldn't we? And it's a really challenging area, but that is something that I think we really need. It's a difficult nut to crack, but we really need to figure out a way of working towards that. As I said, Health Scotland helped monitor the progress of these of this Chief Exec letter, and so against all these areas, physical health, physical activity is an area which we've seen great improvements on, across all the settings. We'll hear a bit more from the tests of change about that, so I don't want to talk too much there, but I guess the key issue and the key message that we've had from the Minister is that this should be part of the DNA of health service. This shouldn't be an add-on. It shouldn't be something that is an extra requirement that is difficult to achieve. It should be part of the DNA, part of healthcare, the healthcare package, health improvement, or these things around behaviour change at an early stage. We've seen all the evidence. It's about a bit of a system change, but it should be part of the DNA. And I know we get a lot of feedback about how it is challenging, or people don't think it's their role as a clinician in a general healthcare setting, or they don't think it's their role because they're looking at the psychiatric illness as opposed to physical health. But I think we really have the evidence now to challenge that. So, as I've said, we've had the Year 2 annual reports, and there's a mixed report card. We're not doing rating scales on boards or anything like that, but there is a mixed report card. We're building on local practice, and there are some great examples of local practice, and we have evidence. I compel you to go. We've got a knowledge network portal for mental health on the Health Promoting Health Service portal. So I'd encourage you to go to that. And of course, Health Scotland have been supporting the tests of change sites and using an improvement approach, and we'll hear from that in just a bit. But I really, I guess, from my point of view, looking at this programme as it's evolved, we really want to use the Chief Exec letter and its updated. The update of the Chief Exec letter to really drive this practice at a national level. It's something that we really want to help support. So before handing over, I'd encourage you to find out more or who your local lead is for Health Promoting Health Service if you don't know already, and go onto the Knowledge Network. And I'm delighted to hand over to our Tests of Change sites who've been doing all the work really locally to try and drive this practice. So first of all, it's Chris Kelly from Greater Glasgow and Clyde, and Chris is then going to hand over to colleagues in Forth Valley. Thank you very much.
going to say good afternoon. I'm not actually sure of the time. I think it's maybe I've just made it. I'm the guy at the end. My name's Chris Kelly. I'm one of the physical activity leads for NHS Greater Glasgow and Clyde. Acknowledgement there to Tommy and Moira, who are also kind of leading the implementation of the test of change site within Greater Glasgow and Clyde. These guys do all the work. I'm just here to take all the credit. So in terms of what we did within Greater Glasgow and Clyde, just a kind of quick recap of our kind of test of change methodology. Here's our PDSA cycle, our kind of plan, do, study, act. So what was the plan within Greater Glasgow and Clyde? And again, this is, I suppose, the same as the other test of change sites, but was to identify the challenges in implementing physical activity brief interventions within a range of mental health wards. I suppose the key thing I want to kind of highlight is the how part. That's the kind of real thing that we wanted to get from this, was actually how does this work in a variety of mental health wards. We've already heard from the kind of speakers this morning in terms of the challenge. We know that the likelihood is that the patients with mental health are going to be less active than the general population. So it's more about how do we actually go about supporting staff and implementing a physical activity brief intervention. So within Greater Glasgow and Clyde, we had 13 wards participating. They range from forensic, IPCU, older adult, rehab and admission wards. Now, the rationale for having so many wards was because each ward individually is going to have its own set of challenges. One size won't fit all, so what works in potentially an admission ward isn't necessarily going to be the same thing that will work within a forensic ward, for example. So that was one of the kind of key things that we wanted, to get a range of sites and to test what the impact will be, what the challenges, what the successes be in implementing a physical activity discussion, essentially, with patients. In terms of the deliverers, I'm kind of mixture, staff nurses, charge nurses, physios, whole range of staff involved. And the pilot date, pilot started in summer 2014. Now, there is a bit about, did we bite off more than we can chew? And the simple answer would probably be yes to that, in all honesty, and we'll look at some of the kind of rationale for that. But we'll get into a bit more detail this afternoon in the workshop, and we'll get the chance to kind of actually hear from staff in terms of the kind of challenges that was implemented. So here we have the National Physical Activity Pathway. So this is essentially what we're looking to implement. And this is produced by Health Scotland. And it's not just within mental health, kind of Lorna touched on it there. This is happening right across secondary care. So my role as a kind of physical activity lead is to embed this, whether it be within cardiac rehab, mental health wards, kind of cancer screening, anything at all. We're looking for staff to raise physical activity. That kind of positive inquiry around physical activity, the same way that potentially happens with smoking and alcohol at the minute. So essentially this is a screening tool where we're looking to find out what the activity levels are at the minute of the patient. Are they meeting the current guidelines of 150 minutes? And if not, are they interested in becoming more active? And then what should we do after it? So in terms of our data collection, we used a spreadsheet that was developed by Katrina Hayes, part of the kind of quality improvement team at the Scottish Government, slightly modified just to find out what the activity levels are. So essentially we're measuring status, and this is something that would routinely happen, maybe for alcohol, within primary care, it happens within Greater Glasgow and Clyde. So how active is that individual at the minute? So we would screen for that. If they are, in this case, doing kind of less, 30 minutes and less than 5 days, then we'd be looking for some kind of intervention to be delivered. So we're just trying to collect a bit of data here in terms of kind of build the picture. But as I said, more importantly for us was actually looking at, well, how did the staff implement it? What were some successes? Where did this work? When did they implement it? So was it on admission? When they're doing maybe other kind of screening? Was it on discharge? So the idea was to try and find out what was the reflection of the staff? Where did this work? To try and build a picture to then take it forward and try and embed this into the mainstream within board policy. So what did we find? I suppose one of the kind of main challenges that we found was actually kind of getting the data back. I suppose when we sometimes when you spread yourself too thin, and there isn't really the support there from the kind of project leads to support staff on the ground at individual wards. And that's something that we kind of need to take on board. So we only get data back from 3 wards. So there's 108 kind of brief interventions or brief advice interactions with patients. So on average, in terms of how many days did the patient achieve 30 minutes of physical activity, it was 0. It was about 0.4. So a very inactive group. The main focus, or the main kind of bulk of the data we got back was from forensic. So again, the data might be slightly different on different settings. And on average, how much time was spent kind of discussing physical activity? And on average, it was 4 minutes. So that would be, we would class that more as a kind of brief advice as opposed to a brief intervention. Brief intervention, we went into a bit more detail and probably take near kind of 15 to 20 minutes and look at goal setting and different things. But again, it's heavily weighted towards one ward. It isn't a kind of mixed right across the board. So kind of word of caution in relation to that. So in terms of some of the challenges, as I said, it's trying to get around kind of 13 wards and find out individually. Spreadsheet was certainly one. The data collection is certainly something we've identified in every ward and how best to tackle that. Again, in terms of some of the tests of change, some of the wards themselves have come up with different recording methods. And again, we'll kind of look at some of that in the workshop. So staff on the ground are looking to kind of change this, and I suppose as a board, how we can embed this into electronic patient records and different things, and how we take this forward. The patient's motivation levels. Again, we've kind of talked about some of the side effects of the medication that people can be on, that kind of feeling of hopelessness, what's the point? But I suppose in terms of that kind of positive inquiry, if we don't ask, we'll never know. I suppose that's what we're trying to do throughout the system, that if we're constantly asking at one point, hopefully it's the right point in time for that individual. For some wards, there's a lack of physical activity opportunities. So in some, they've got walking groups, they've got access to gym equipment. For others, there's very little on offer that they can provide in terms of more secure units for the patients. So once they've raised the issue with the patient, if the patient's motivated and really keen, then what do we have for that patient in order to support them to become active? And staffing capacity in terms of if it's a more secure ward, in terms of releasing staff to support that patient to become active, take them to the local leisure centre, whatever the opportunity may be. So there's a number of kind of challenges in implementing it, and as I said, we'll go into a bit more detail in terms of the workshop. So what are the next steps for Greater Glasgow and Clyde? So obviously the data collection I've highlighted in terms of how we embed that, what works. And that doesn't need to say it needs to be one size fits all. It might be slightly different, but kind of building into a kind of essentially a framework. Staff development, we've talked about training. We did deliver training, health behaviour change training, to support staff to raise the issue. But the feedback would be that actually the staff on the ground delivering the training didn't actually access it. It was more the kind of ward managers in terms of those that access the training. So there's definitely a bit of getting to the right staff. And clearer guidance in terms of what the expectation is for the ward staff in terms of what they're actually being asked to deliver. And obviously, as I said, more physical activity opportunities, engaging with local leisure authorities, try and bring them in for taster sessions so that staff can then, on discharge, when patients are going back into the community, they've already maybe tried something and you're kind of closing that pathway a bit. What I would say to try and end on a kind of more positive note, it's that kind of old football adage, sometimes you learn more from your defeats than you do from your victories. But on a more positive note, what I would say is sometimes I need to be a salesman when I go around the different staff within the NHS in terms of why they should be discussing physical activity. When I speak to staff within mental health services, that's not the case. They're already very aware of the benefits of physical activity. They're already fully on board with it. All they're kind of looking for is a bit of support and a bit of guidance on how to do it. And I suppose that's one of the really, the most positive thing that I got from it was that enthusiasm and that desire to support their patients to become active. So, thank you. I'd just like to pass on to Lynn, who will go through the test of change in NHS 4 Valley.
Hello, my name's Lynn Speed, as it says there. I'm a physiotherapist working within mental health in Forth Valley. I was employed 8 years ago. One of my main roles was to promote physical activity within the mental health care group. And little did I know at the time that I took the role what challenges I would be facing. In terms of the numbers of people that we're potentially targeting, in Forth Valley, out of a population of 300,000, we've approximately, and the term approximate has come into a lot of our data collection because we don't have robust data collection systems in place. So I was given an approximate number of 8,575 adult patients recorded as having a mental health diagnosis. In terms of secondary care, we have 3 acute adult inpatient wards with a capacity of 54 and 2 elderly psychiatric wards, one of which is functional and one for organic. And I'm not sure whether that in itself is statistically significant, that we've gone from 54 to only 20 beds once people get to the age of 65. We also have a community hospital with 3 wards and 3 bungalows, so another 59 inpatient beds. We looked at some of the data that had been collected previously, and it was quite interesting that the majority of people, well, almost half of the people that we were working with have over 10 years contact with the service. And over half have had 1 to 5 admissions. 34% of people were admitted within the last year, and 17% it was their first admission. So when we're looking at this, it's really telling us, I think, that there are lots of opportunities for us to be able to have a contact and a discussion with people. So it's not just about the first contact within acute services. They're around for a long time, so we need to make sure that we are reaching everyone. How we record that, we're not quite sure. It was decided before that we introduced the test of change on the acute wards that we needed to go through a consultation process. It was generally acknowledged that there was a lack of knowledge on the specific interventions required to improve physical activity in our mental health population, and who was actually using the mental health services. How old were they? Were they male, female? What was the diagnosis? We hadn't explored specific barriers to physical activity. We were making a lot of assumptions. We could use national and international data, but locally we didn't have that information. Neither had we talked in great detail to our patients to find out what would help facilitate physical activity or the activities that they actually preferred. And what were we offering? Did it meet patient expectations? So it was agreed that over a period of 4 weeks, so it was January 2014, that we would do a survey of all inpatients in 2 mental health units and 3 community mental health teams, and that was led by Jim Crabb. We'll be talking more about the outcomes from that in this afternoon's workshop, Barriers and Enablers to Increasing Physical Activity. But the general outcomes were that most patients and staff recognised the importance of increasing physical activity, and many of the patients had multimorbidities that also needed addressed. And the word hopelessness, I think, has come up several times already this morning, and that was a word that came up several times when we did the survey, a sense of hopelessness among both staff and patients. When we got to look specifically at test of change, we adapted the Scottish Physical Activity Pathway, and it was decided that at the 72-hour care plan review, all patients going through one ward would be asked these questions. It was decided we weren't, the staff on the ground weren't wholly supportive of us introducing it across the board. They wanted further evidence that what we were proposing would have a direct benefit to the patients in their care, or in our care, I should say. So this was the process we went through. So from this, and we had a sample size of 59 over a 5-month period, that on that one ward, 40% reported that they had already achieved 150 minutes of physical activity in the past week. 20% weren't interested in becoming more active. 20% were discharged before we could even ask them the questions. And 20% were referred on to our physiotherapist for a weekly brief advice, brief intervention group session on the ward. This posed questions around accuracy, because in our survey it was shown that only 12.5% of patients reached the 150 minutes of physical activity in the past week. When we looked at the people who'd given those answers, we found that the majority of them had bipolar affective disorder, and they were in an episode of mania. So it, in a lot of ways, discounts that as a figure. What we did find that as people got better, although there's change in their clinical presentation, their answers became more accurate. What we also found was that what was observed on the ward by other staff while people were unwell, people would say that they weren't active when they were, and they were active when they weren't. So I think learning from this was it wasn't necessarily the best time in the patient's care to be asking the question. We went on to look at across the allied health professionals, how many. We did a snapshot in a week. It was actually in January this year, to see how many of the staff who had already had training in implementing the physical activity pathway, giving brief advice, brief interventions, who had been encouraged to do the online module, how many of them actually were engaging with the process. So out of the staff who replied, and it was 77 patients who were screened over that 5-day period. It was found that there was 40% didn't want to be more active. Again, we're getting discrepancies in what we found on the board. So 40% didn't want to be active, so they were given booklets. 55% were wishing to be more active and were given a brief advice. Time has always been cited as an issue by staff as to a reason for not engaging in brief interventions with their patients. So, but when we looked at it, that only actually applied to 1% of the people considered. And of the 4% there that were given brief intervention, they were all, in fact, people who were being seen by, dare I say, physiotherapists. So we were looking to see, really, out of our HPs, who were on board with the message and who were actually using the pathway. We went on then to, well, if you're not using the pathway, do you actually ask about physical activity? And of the 55 staff, we only had 12 respondents, but you can see from this that although there's a low number of people, again, it was the 4 physiotherapists using the physical activity pathway, that all 12 members of staff said that yes, they were asking about patients' current level of activity. And most felt confident about discussing the current recommendations, benefits, barriers, and looking for solutions, and were happy to spend a few minutes doing that. Quite a significant number said they were confident in delivering a brief intervention, which took a bit longer and involved a more detailed interview with their patients and specific goal setting. 7 people admitted to doing the online raising the issue of physical activity module, which may not sound a lot, but as a clinician trying to promote this, it's still better than the none that we had the year before. In terms of resources that people used, people were very positive about the Raising the Issue booklet and the A4 sheet, which I know is available on the in the marketplace. There were some other resources being used that were more age-specific, such as Staying Steady and the Age UK from Age UK and Up and About from Age Scotland. One quote from a member of staff said, "I do quite a lot of physical activity myself and absolutely know the benefits. I'm a bit sparing of influencing clients. I will try to be more aware and positive." And I think we need to just keep raising the profile, to keep getting the message out there so that people don't then put it into, I'll do it if I've got time. So in Forth Valley, what are the positives? What are we actually doing to try and make sure that staff have the information they need to increase the opportunities for mental health patients to access physical activity? We're doing staff training and an in-service programme, and that goes across the board and includes nursing staff. We're promoting e-learning. We are screening people as they come through the door, using as much as we can using the physical activity readiness questionnaire, which looks at other barriers to people actually engaging in physical activity, so we can address those issues before they engage. We're using outcome measures to show change. We're putting in patient education systems as part of existing interventions, so rather than it being a standalone, we go along to anxiety management groups. We say, can we have a slot? And any other group interventions there are, we try and elbow our way in, and we'll do between an hour and a 2-hour session and try and base it on the brief intervention and try and make it as interactive as possible with patients going away with goals. And generally those are quite well received. We're trying to develop pathways to identify the patients who need additional support. Some people have other issues such as comorbidities, all the comorbidities, and social anxiety is a major obstacle. We're giving opportunities for various physical activity sessions, exercise referral, liaison with the community. We have groups specifically for people in the community with mental health issues and comorbidities and barriers. We've got peer support and volunteer programs. We're putting in a grant application to Excite to come in and provide gym-based sessions at hospital sites. We're putting together a conference in 2 weeks' time to try and raise the issue, and we have a physical health and mental well-being group. So I've come today, there's lots of learning, a lot more questions, I think, than answers. So hopefully I'll go away with other people's experience to take back to Forth Valley. Thank you.
Good afternoon, everyone. As Lynn said, my name's Kevin Lyle from NHS Ayrshire and Arran. I'm a health promotion officer within the public health team, and I'm going to be co-facilitating today, thankfully, with my colleague Anne Fisher. To introduce myself a little, similar to Chris, my role in introducing the secondary care pathway into mental health services is one of linking with the mental health services team, but also it's about linking with other secondary care areas as well. So that would include orthopaedics, AHPs, occupational health and so on. So to introduce the Chief Medical Officer's CL that Lorna had also mentioned earlier on in her presentation, defines, or in relation to physical activity, asks for defined pathways for delivery of brief advice and interventions, and that is now a performance measure within the CEL. Around about the time the CEL was introduced, there was also the Scottish Physical Activity Screening Pathway was put together as well. This provides great support with embedding pathways to support physical activity into practice. And as you all know, bringing about change does not happen overnight. And as we progress through the presentation, we'll try to tease out some of the steps that we've taken within Ayrshire and Arran to bring about this change, to having a formal recording mechanism for physical activity with patients within mental health services. So what was our aim? It was to ensure that a phased implementation of the ScotPASQ within mental health services in Ayrshire and Arran was embedded. So initially this happened within 4 mental health wards, and there was a 6-month comparison done, which will be the focus of today's presentations once Anne comes up. We're also currently working with the community forensic mental health team and the one community mental health team within a locality of South Ayrshire. So what were our objectives? Objective was the team has knowledge and understanding of physical activity pathway and why it is important to raise the issue with all patients. So what we were trying to do there was we were hoping that team members would be familiar with the physical activity pathway and the guidance surrounding it. Team members would be available to attend training opportunities that would come with this, and team members were aware of the importance of physical activity and prevention of treatment and recovery. So our second objective was the physical activity screening question is embedded in routine process. So we're looking at local forms and tools and processes being updated to incorporate the physical activity screening question. Ensuring that the team are comfortable with asking the question and have adapted it to suit their own style and the patients that they're working with. And we were aware of any barriers to raising the subject and make sure these barriers were identified. We're also hoping that team members can provide brief advice or brief interventions or refer to a suitable person when appropriate. So for this, we were hoping that information on physical activity is easily accessible. Team members were comfortable with providing that advice. Team members were aware of the key skills in motivational interviewing that would bring about this change. And where brief interventions are required, time and people would be available to provide this service. Finally, our last objective was the team are able to do tests of change using PDSA cycles to collect appropriate data. So we're hoping that straightforward data tools to minimise burden on staff would be developed. The team understand the concepts around the tests of change and are comfortable to do this within their own working practice and introduce the physical activity pathway, and tests are documented and shared along with the data so that we can then act upon the data that we collect. I'll just pass you over now to Anne Fisher, who's a senior charge nurse in one of the wards that were actually implementing the process.
Thank you. And I didn't fall, so that's good. Not promising the way back, but Kevin's going to catch me apparently if I do fall, so that's fine. Yeah, my name's Anne Fisher. I'm senior charge nurse in one of the rehabilitation wards at Ayrshire Hospital in Ayrshire. I became involved in this probably just about the back end of last year, and we started looking at the planning for the work that we were going to do. I think, having heard what's already happened in other areas, ours is probably on a much smaller scale at the moment, which I'll talk to you a wee bit about. Through our physical health and mental wellbeing group, we agreed that it was very important that we wanted to look at rolling this out across all mental health service within Ayrshire. One of the clinical nurse managers, who was very enthusiastic about it, decided to take it on through the rehabilitation and forensic units within Ayrshire. That consists of 4 wards. So what happened initially in May, there was a meeting with Kevin, I believe, and Stuart McKenzie, who's our clinical nurse manager, with all the senior charge nurses of these wards, and just to start discussions to see how interested they would be in taking that on. They were very enthusiastic, me one of them obviously. We then met with some of the staff nurses on the ward to see about their enthusiasm, what their understanding of the importance of why this had come about. Again, they were very, very enthusiastic to carry on with it. We provided written information to all the staff, to all the wards, in the form of some of the information you've got in your pack about the ScotPASQ. We then introduced all the staff that were going to, there was probably about 2 or 3 staff on each ward area were going to be involved in actually taking the patient through the pathway and talking to them, doing brief interventions and brief advice. So we identified those staff clearly at the beginning, and we identified some of the local referral pathways that we already had in place. The local Keep Well team we plagiarised a lot of the work that they had already done in terms of physical activity pathways. And we also looked locally at what we had within the Ayrshire Hospital. There's a physiotherapy gym, which we utilised. One of the wards has a small gym in their own right. We also have a big piece of work going on with the NHS screening of the grounds. So there's a lot of walks already available to all the patients and the staff. So we were using that. There was also a branching out programme, which has just recently finished, which was about using the environment and looking at the woodland areas around about the hospital. So we were utilising all those as referral pathways. Data collection, similar to Glasgow, we used a similar tool. So the nurses within the ward would have the discussion with the patient, they would record it on the ScotPASQ, and that data was then sent to, we were fortunate enough to have a small amount of admin support who would collate all that for the 4 wards, so we're talking a lot less numbers, and they would collate that onto the data collection tool. we started and we implemented the pathway and doing that in June 2014 within the 4 ward areas, and then we repeated it in the same ward areas in December 2014. Now, the presentation is very much about how we implemented the pathway, not so much about the outcome, but I thought I would just put up some of the information. So on the left, you can see the first one that we did, and in December, the second one. 43 patients now, I think if I'm right, maybe Cam in the audience can confirm, I think there's 46 patients across these 4 wards. So we've managed to capture, by the second one, we've managed to get all these patients to participate in the ScotPASQ, which I think has been really positive. I think one thing that shows with the figures there is that by the end of the second one, 76% of the patients felt they were meeting the guideline. Now, I think, that's perhaps perception as well. I've got 12 ladies in my ward, and 11 of them said they were meeting the guideline of 30 minutes a day. And again, I think that's a wee bit of perception, perhaps as well, maybe a bit of a training need with the staff to look at exploring that a wee bit more and identifying, well, how is that? A lot of my ladies, they are out walking to and from the smoke room with it, or the smoking environment within the ground. So there is a lot of walking that goes on, but just like we've said everywhere else, a lot of other unhealthy behaviours around that as well. So I think there's a bit of work that we do need to do, but I think personally it's really positive. We've managed to get all the patients to engage in those 4 wards, although it's a small area. I think also what I would probably do now is where I've put only 3, I would take the only out, because I think 3 of the 11 that said they weren't meeting the guideline, they were interested in becoming more physically active, and I think that's really positive for this particular client group, some of which have been in hospital for 30 years or more, so I think that is really positive. It's a good start. The learning, there is potential training needs, I think, for some of the staff. When we went into it, the staff were very confident that they were familiar with brief advice and developing brief interventions and referring on, and I do think they are. I think it's maybe around the tool in itself, so we're going to lay on some training in the future, just very in-house training, sitting down with the staff, going through it and practice and doing that together. Developing more robust data reporting template, and that's more about probably for outcomes for us to see, well, okay, people said they were interested in being referred on, where did they actually go, did they actually turn up? So it's more about local information for us to see, is it working, is there an outcome at the end of this, that people are actually doing it? But at the moment, the focus of this is about doing the ScotPASQ, raising it as an issue and making it an important fact, and I think we are achieving that at the moment. Locally, and everywhere else we've heard this morning, the pathway links very nicely to a lot of the physical health checks that are happening already for a lot of our patients. Again, this only focuses on rehab and forensic, and I know obviously within acute settings that there are physical health checks that go on an annual basis and more when required. I think probably in Ayrshire, what we are looking at currently is how we link that better, how we bring that all together, how we bring the Health Promoting Health Service together with the SPSP work that's going on, there's so many links in the Commitment 28 that we've talked about for our patients on clozapine. For me, a wee bit in Ayrshire, maybe it's just because I'm quite new from December, it's a wee bit disparate at the minute, and I think through our group that are going to talk this afternoon, we're hoping to pull that work together, and formulate it a wee bit better locally. We're probably not as far down the line as the other 2 board areas, because the stage we're at the moment, we have this data, we have the information currently. What we're now looking to do is go back and ask the staff and get more information how they felt about doing the pathway, and then we will have that. This is just a draft of the questionnaire that we're going to use to do that. And then learn how they've felt implementing the pathway with the patients and what that's meant for them. Has it improved their knowledge? Is there more training needs that we need to address? The way forward, local training, I've just said that. One of our community mental health teams in the south is my colleagues here today. They're starting to implement that within one of their clozapine clinics. We're doing this very much in a phased approach, so rehab and forensics, we want to get it right first, and that's why you're doing the questionnaire, getting the data collection tool, we want to get that right first, and then our colleagues in the south will take that on within the clozapine clinics. Our forensic community mental health team are also looking at taking it on with all of their patients, again, once we phase this in. And we have a furniture workshop, which is based in the grounds of Ayrshire Hospital, and the charge nurse there is very keen for all their patients that come through the doors there to get that done there without duplication, obviously. And Kevin put these nice links up, which would be very useful. I think so too. Thank you. Oh, sorry.